All right. So we, I am standing on behalf of other co-authors, and I will be telling you what we did in looking at intermittent fasting to reduce chronic illnesses and as well expand it to psychiatric illness. So you might be thinking, what's kind of this? Fasting is not a new thing to us. But when we say intermittent fasting, we will let us know the concept through this narrative review. So this is just about me, and I'm a baby lecturer at that department. And my research focus, why I'm presenting this, is bringing herbal medicine into psychiatric care. So we look at this because of time. I'm going to skip that. Yes. Intermittent fasting is what we call timed eating. It is not what you thought. It's not about abstaining from food all the way. But it is timed fasting. That is an altering period of eating and extended fasting. You have a period of eating and you have a period of fasting. So it has been documented to be useful in preventing a lot of disorders. And that is what we are also talking about, innovative idea. Those that will carry out the innovations should also be. Yeah, the purpose is we carry out the narrative review to look at how this intermittent fasting specifically reduces type 2 diabetes, cardiovascular disorders, CA, and other neuropsychiatric disorders. And some will be asking, why all this? Why all this? Why this? All right. Why this? Why intermittent fasting? We've been fasting, and why are you coming with intermittent fasting? Actually, I started this research 6 years ago, and we had breakthrough in the process. And many of the clients, those people that we assisted, 85% of them happen to be nurses. You know, they develop DM, and in the process, they have infected leg wound. And many of them said they will not allow the doctor to cut their leg, and they called for help. So when they came for help, we started the research, and by the grace of God, we have been able to rescue all of them by the grace of God without amputating their leg. Yes, thank you. Thank you very much. So what brought this was a few months ago, someone called, said, John, we heard you have developed cure for type 2 diabetes. And I said, no, I have not developed cure for DM. I have only developed, by the grace of God, cure for cutting legs. So that when you have wound and don't want to cut your leg, you can reach out to us. But when the person now said that, something in me just said, yes, you can at least move forward and look at how you can at least do something to cure the hair. So a few years ago, I launched into intermittent fasting. Then when this person said this, I went back to the theory of intermittent fasting and started in my laboratory discover how to cure DM. And this is what I am presenting to you now. That with intermittent fasting, you can reverse type 2 diabetes with intermittent fasting. Yes, and that is why we are bringing in narrative review. But before we launch into that, these are the enemies. You know, if you have a cure, you are doing fasting, and you don't take away what is causing the problem, you are just suffering in vain. So I discovered that those people that came in with DM, they have been hitting this for more than 35 years. Sugar in our body. Sugar is termed to be the best enemy of human being. How many types of diabetics do we have? Two types. Okay, so in my own research, I've added 2. So I know we have type 1, type 2, type 3, type 4. So which one is type 3? The excess of sugar in your brain is dementia. It is type 3 diabetics. Excess. When you consume sugar more than necessary, accumulation of sugar definitely destroy brain cells. Then when you move further, you eat a lot of sugar, the whole body gets infected with cancer. So why that theory? Why that theory? The theory is just basically on the insulin resistance. Insulin resistance. You know, when you consume sugar, you are eating sugar more than necessary, the body will absorb what the body needs. The excess of those sugar will be, you know, as you are doing it often and often, the insulin will not be able to carry the sugar to where they are needed in the body. And they said they hide in the, you know, in the liver, and they distribute the excess sugar to parts of our body. And to different parts of our body, and that is why you see those days, women are the ones that are carrying baby. But today you see men coming with big baby without fertilization. So you see them, what is causing that? Excess of sugar that they have consumed. And you know, that's in a way, body will distribute it to parts of our body. For men, you see their stomach coming out. And the woman, the wife, you greet your wife that she's doing you a good thing. No, she's not. So for women, it will be distributed to other parts of the body. And the study have shown that when you have insulin resistance and you still kept eating sugar, you have maximum of 10 years to develop diabetes. That is the theory. So for our review, we look at narrative review, as I've said. We did some methodological search. We look at PubMed, PMC, Embase, and the rest. And we are able to review 20 articles, limiting it to recent so that we can at least handle what we have. Then the study was based on meta-analysis, randomized control trial, and the mechanized review. Mechanized review is a kind of review that tells us the nitty-gritty of effects of the intervention, not just the outcome. Then we want to see those that have risk of DM and other chronic disorders. Not only that, we also look at people with mental disorder, and we jettisons those that are with children and non-animal based. So our result was thematically discussed, and we have all this through our results. We identify, number 1, types of intermittent fasting. varieties of types. We have fasting for 24 hours, fasting for 16 hours, fasting for 72 hours, fasting for 2 days in a week, alternating fasting. But these are the prevalent in the articles that people really use. 16 to 18 time resisted feeding. What does that mean? It means you have 16 hours of fasting and you have 8 hours windows of eating in a day. And we are told that it is most tolerable and people practice it consistently. And it's good for, when you want to help your insulin to be sensitive. And that is why I said this is the cure to type 2 diabetes. You want to revive your insulin to be able to absorb sugar and take it to where they are needed in the body. This intervention is free and is promising to reverse those people with type 2 DM. People with overweight also can participate. People with obesity can as well do it. People with insulin resistance can as well do 6 to 8 intermittent fasting. Can start with that. So it has good advantage in that we have low drop rates of people practicing this from our literature review. Then the second most popular one is 5-2 fasting. That is, in a week, you fast, you eat your regular meal for 5 days, and you have 2 days of fasting, which is not mandated to be, consecutive. You can just decide to take any of the 2 days and eat your food, then and take more than another 2 days to fast. So it is moderate. It has moderate adherence. And this require discipline. So all of them require discipline anyway. It is very effective in reducing blood sugar and cholesterol. It also has moderate dropout. The last one, most popular one, is alternate day fasting, where you eat today, you fast tomorrow. In the next 2 days, you fast and do the rest. Though this one is very effective but has higher dropouts because people want to continue to take in sugar. Then our next identified intervention is, the results that we discussed thematically. Second point is we look at type 2 prevention from intermittent fasting, that it has weight, it has strength to reduce all the biomarkers of DM were found to drastically reduce. So the mechanism of this is what I presented in the diagram. You see, when you take in excess of sugar, you bring in more insulin into your system. And when the body burns the necessary one, we go and store the unused one in the storage and convert it to unnecessary fats and distribute to aspects of the body. But if you include intermittent fasting, you see that you cannot see insulin in the second one. If you include intermittent fasting, during the fasting, insulin is not released. So the amount of energy that is needed, the body will go back to the storage where the excess of sugar was stored, and we convert that to what is known as ketone. And that ketone will be used by brain and other parts of the body to generate energy required by the body. And it has been proven that that ketone is very efficient without any side effects. In fact, ketone has been proven that has ability to revive destroyed insulin. We revive that insulin. Then the next thing that we did was to look at effect on cardiovascular disorder. Yes, it was fantastic to identify that it's capable of taking away bad cholesterol, capable of lowering blood pressure, capable of lowering heart rate, and capable of lowering inflammation in the body. You agree with me? You know, some of us, we were told that when we don't take cholesterol food, or when we take cholesterol food, that is when we have high blood pressure. If you see the second diagram, a lot of things resulted into that plague, that thing that is, blocking the free passage of artery. And that is the main reason why many people are suffering from high blood pressure. The drug they gave to us will not remove those plague. Will they remove it? The drug will not remove it. All what the drug will do is just to expand that, and we allow the thing to move. And as you keep taking the drug, one day the drug will not work on that vessel again, and the person will kick the bucket on time. So what this intermittent fasting does is, when there is no glucose, when you are not bringing in glucose, the body will go to this artery where this thing lodged. We tap from that lodged fat, and we convert it to ketone and use it. And before you know it, you just stop taking your high blood pressure drug. So for mental health, where I finally find myself, we have seen that intermittent fasting will help to increase the availability of brain-derived neurotrophic factor. Neurotrophic factor is a protein in the brain that helps in the maturity and the development of neurons. And we all know the potential and the efficacy of neuron in the brain. So when the protein is increased in the brain, there will not be problem with people suffering from psychiatric disorder. So it has that ability to improve their mood. Another one that we discovered is it improves memory. So it boosts memory, and it also protects brain. You know, the other time I said inflammation. So it reduces inflammation by dealing with interleukin-6 and the C-reactive protein that was, found in the liver during the process of inflammation. And it alleviates symptoms, supports gut health, reduce brain inflammation, and also promotes a lot of neuro health. So practical implication, we have personalization. It's tailored to individual and lifestyles. Yes, this I want to tell us. It is very useful, but you need to seek counsel. You need to know. You come to people that know how to do it, or you go to your physician if they have the understanding. So you can easily reach to us at ABBA, Center for Herbal Medicine and Drug Discovery, if you need all this. Then it's also help us to look at, address hunger and hypoglycemic risk. Let me quickly tell us, the first day I did this, I practiced this on my own body. So the first week I did it, I nearly collapsed. In fact, I was in church, and I just saw that I was going down. What happened? Nobody knew what happened. So I quickly ran to a place where they are selling Coke. So I drank that Coke. And somebody will say, but you said we should run away from sugar. So that is things that we need to tell you when you come to us. So we need to address the issue of hunger. hunger is there when you are doing intermittent fasting. At that particular time that you have customized your brain to take the breakfast, the lunch, and it will bite you. But you need to know what to do. So what we want to, our own contribution is you need to start at the small level. You need to start. If you want to practice it, you start at the small level, like 6 to 8, and you can improve more. Then the gaps that we identify that other people can research on, the postgraduate people can look at those things that we have identified. And what is future direction? Future research should focus on long-time human trial. The literature that we harmonize, they did human for short period and limited number of people. In summary, I want to tell you that intermittent fasting is very efficient and proving to be a good intervention that will help us to live an healthy life. Thank you very much. Yes, thank you. So before I leave, I promise from ABBA Center and Drug Discovery, I promise to give us these gifts. Men at home are suffering from this prostate enlargement. So we discovered this drug of recent that anybody that is suffering from what's it called now? Prostate enlargement. So this a call proving to be very, very potent. Very potent. So all we need to do is listen. No, I'm about to leave. So because if you come after this, you are going to pay. So because this one is free. So what you do is get the leaf, wash it thoroughly. You can dry it because it's very scarce now. Very, very scarce. Somebody had the problem and I took it. I saw it around my house and I took part of the leaf. I gave to the man. I said, use this thing for 3 months. He used it for 1 week and he ran. He came to me. He was celebrating that said, use it for 3 months. He used it for 7 days. He came. By the time he came, I don't know what happened to this woman. No. One woman went to that place and cut the thing from the root. And we have been looking for it. So if you have it, you wash it, dry it in the sun for like 4 hours, and continue the drying at home. Grind it and cover it in a airtight container, so you might not know when you will need it for anybody that is suffering from prostate enlargement for 3 months. Thank you.
A round of applause. Thank you.
Okay, she said, how do we use it? Thank you. So to use it is, if you are using it fresh, you boil it for like 10 to 15 minutes with 700 ml of water. So for 15 minutes. So when you want to use, I bring in my own innovation anyway. So you take 40 ml, 40 meals 3 times in a day, and the person will be fine. For 3 months, the handful of the leaf. The leaf with the flour, please, leaf flour. So yes. Then, so for the first week, the person will be relieved. Please let the person continue. One thing about herbal medicine, it is not meant for emergency care. So herbal medicine takes time before it works. But when it begins to work, you will appreciate it. So for the first 1 week, the person will see the changes. In fact, people that are with catheter, For the first 1 month, the catheter will just drop. But let them continue to use it. Thank you very much. Dry one. So if you have the dry one, grind it very well. 1 baby spoon in hot water or hot pap. It will do the magic. Thank you.
You can see him behind the scene. Thank you for that beautiful presentation, Dr. Makoju. So you can see our Abba nurses working. So intermittent fasting can reduce the risk for developing type 2 diabetes. And it's very correct. I have a quick one to share with you. My father was once diagnosed of he fell on his way back from work. So they said he was hypoglycemic, that he has not been feeding well. He was a banker. That's why he should try to eat. So he began to eat Igbo food, eat everything. Exactly a year after that, they diagnosed him of type 2 diabetes. So he became confused and said, one him was hypoglycemic. So now again, it's no more hypo. It's now hyperglycemic. That what is it? So when he told me that, I was just a young graduate. I just finished from school then. I just finished my service year. So what I did was that I just went back to lifestyle modification. That was the first thing we did. We had a 2-week timetable diet that we didn't stop taking carbohydrate, please. We took every classes of food, but we reduced the carbohydrates. My father fought with me. Just 2 slices of yam with a whole lot of vegetables so that the stomach is not empty. So he snacks on cream crackers in between meals. You have vegetable salads. We mix, but we reduce the sugar intake. You know, he kept saying sugar. So we reduced that carbohydrate intake, and within 2 weeks, something beautiful happened with that hyperglycemia. And in about 6 months, within 6 months or a year thereabout, he returned back to normal diet. And till today, I'm talking of 2010, till today, 2025, he never used any anti-glycemic drug. We just controlled the diet. He's been fine, and now he can eat like me and you. What I'm trying to stress is that trying to rest your insulin. When you rest that pancreas, it has the ability to kickstart again. So you need to reduce your starch intake, increase your protein, eat other food in between, but try to reduce your sugar intake the most. Thank you very much. So very quickly, please, we are mindful of time. We're going back home. Oh, sorry, Ma, you have a question? Okay, actually there are room for questions, but we are just trying to manage our time so that people can. So let me give Prof the permission to ask a question.
I have many questions, but I will just ask one. Thank you very much. That's the delivery of a dokita, and it's a good welcome gift. We are grateful. You've been talking about intermittent fasting, and we know that fasting is good, just like you have identified. But I want to ask, what is the role and place of water during fasting? Because one major negative effect of fasting is the kidneys suffer. Is there a place for water intake? Then you talk about 5-2 fasting. The 2 days you are fasting, do you eat in the morning and you don't eat in the morning, you just eat in the evening? Or the 2 days is just continuous fasting for 2 days? And is it a continuous thing every week, day in, day out? Thank you very much.
Thank you, Prof. Thank you for that. Please, let's listen, please. You know, I said, if you want to go into it, you need to see us at Center for Herbal Medicine and Drug Discovery. At least you will see me. They refer you to me anyway. So you can also see me. When you want to do intermittent fasting, it's a procedure. What is the goal of doing that intermittent fasting? Do you want to reduce your weight? Do you want to cure one disorders or not, or another? So we place you on what to do. For mommy's question, when you are fasting, in intermittent fasting, the goal is to bring back your insulin sensitivity. So during the fasting, you have this water to go around with you. And when you are doing intermittent fasting, you don't just drink any water. You drink, because when you are fasting, you are losing electrolytes. And if you are not replacing it, you just see that you are weak. So, and that alone can cause another problem. So, if you want to drink water during intermittent fasting, I would recommend Biggie. Why Biggie? Biggie has electrolytes. So, it has been fortified with electrolytes that when you are fasting and you are drinking this, it will replace it. Another type is if you cannot get Biggie, if you can get sea salt in your water, just like small sea salt inside water, you drink water when you are doing intermittent fasting. It is not a religious-based fasting. You can fast, drink water. In fact, when you are fasting, you can eat something like vegetable, things that will not go with anything called sugar. Are we together? So, because it is the sugar that is killing our people. And you know why I came with this thing is because nurses are coming here. This presentation was meant for scientific conference coming in September. But I just decided that since nurses are coming here, and nurses are the one I'm taking care of, many of them are coming with DM and they want to cut their leg and they are refusing cutting their leg. So we can prevent that with this. So another question that Prof asks is 5 or 2. So the 5 days of eating and the 2 days of fasting is fasting with water. That 2 days does not necessarily mean you do it consecutive. That you can do it maybe Wednesday and Saturday. So I eat all other day. So the good thing is, please, you need to start with kekere aspects and look at the reaction in your body. So make sure before you do it, it's not meant for everybody, please. If you know that you are overweight, go and do your BMI. If you are overweight, go to the laboratory and do your blood glucose markers. Not only blood, do HbA1c, another insulin resistant biomarker before you venture into it. If you are taking insulin injection, please don't do it without seeing us. Thank you very much.
Thank you. All your questions, you can see Mr. Make at the back of the scene. Thank you very much. So our next presenter is Dr. Elemile. And she has promised us to manage our time. Thank you.
Good afternoon to you all. I know that we are somehow tired, but I promise you that I'm going to manage my time. Permit me to still standing on the existing protocols. I'm here this afternoon to present to you the abstract titled Awareness and Prevention of Occupational Hazards among cement sellers in Akure, Nigeria. I should continue. You know, I'm a community health specialist. And being in the community, we deal with different group of people. So this afternoon, I want to take you to a group of people that their major work is on building, most especially people that sell cement. This work done by me, Elemile Mayowa Grace, and Ogidon Sarah. So if you look at this picture very well, you can see a man carrying something. Who can tell me what you can see there? What is he trying to carry? Cement, okay. And if you look at that man that is trying to assist him too, they are not putting on anything. And my topic says, the assessment of the cement sellers about their awareness and the preventive measures, practices concerning the prevention of occupational hazard. By virtue of introduction, the cement industry is one of the prominent and most essential industries globally, contributing to the economic growth and development. In multiple Nigerian and global studies reported that about 62.9% of workers had chronic respiratory illness as a result of prolonged exposure to cement dust. Different investigations reported in Africa that the cement industry is a cause for many types of injuries, mainly born of a different part of the body, fracture, falling, and hospitalization. Even it led to high cost of treatment and loss of productivity. And when we look at this, we discover that we don't really have much information about this in Ondo State, and that is why we ventured into this research work. The main aim of this is to assess the awareness and prevention of occupational hazard among cement sellers in Akure, Nigeria. Of course, the significance of the study. Why do we need to do it? At the end of the studies, the document can serve as a reference for further research work, and at the same time, the findings of this study could be useful in the formulation of policy by stakeholders for prevention of occupational health hazard among cement sellers. I made use of Earth Belief model for this. If you look at the two variables talking about the awareness and preventive measures, and I said I make use of these Earth Belief models. Earth Belief models have about 5 concepts that talks about the sustainability, perceived sustainability, severity, benefits, barriers, and key to actions. For somebody to be able to prevent occupational hazard, it means that there's something they needed to make use of. And that thing, we call it PPE. What is PPE? Personal protective equipment. Okay. And the first picture I showed to you, you discover that they were not really putting on anything. And that is why all these workers, they are liable to have all these occupational challenges. Now, when you look at the Earth Belief models, talking about the perceived sustainability, it means that these participants, if they have the clue on the likely occupational hazard that they are at risk of, they will celebrate using this particular personal preventive equipment. And at the same time, if they are able to think about the severity, thinking about coming down with respiratory disease, or inability to even take care of their children, or they will not be able to work, and they will not be able to have the empowerment in time of money, they will be able to make use of this particular PPE. Also, even if you make the personal preventive equipment available for individual, they can still have some excuses. When I'm talking about the excuses, I'm talking about the barriers. Some may even have the money, they may have it being around, but they will still be telling you that, oh, madam, I cannot even put on this face mask because I discovered that whenever I put it on, I could not work very well. This may be the barriers. But if individually they are well oriented about this PPE, they will be able to make use of it, and that one is attending to the key to action. And for example, if you are able to give education to a cement seller, and you have been able to tell them that if you make use of face mask, definitely it will protect you from having occupational hazard, and they have been able to take that challenge up, then you say that the issue of this self-belief model has been able to work for individual. Now let's talk about the methodology. The design use was descriptive, cross-sectional. Of course, the settings, Akure Metropolis. We make use of people that are selling Lavage cement and Dangote cement. The population, they are cement sellers. The sample size happens to be 557. But with the use of Taro Yamani, we're able to come up with 233 for the sample size. The sampling method, make use of a non-probability purposive sampling technique, was used. And the instrument, we made use of the questionnaire. In that questionnaire, we have about 4 sections. Section A has question on the social demographic, B has question about the awareness, the C has question about the occupational hazard they are prone to, and the D has question on the preventive practice measure that they make use of in their means. Of course, I make use of adapted questionnaire from Sayar and Musa et al. 2012. Then the validity now. That instrument was given to expertise. They look at it and they check the face and content validity of that particular content before we were able to take it to the community. Then reliability was assured. We took that particular instrument to Ekiti State in the midst of people that have the same characteristics. I mean the cement sellers in Ekiti State. We make use of 10% of the sample size. You know, I said 233 happen to be the sample size. So we make use of 23 respondents in Ekiti State to test the instrument. And at the end of the result, we were able to get 0.8 coefficient that make it to be reliable. The method of data collections, we had 3 research assistants that went to the community along with us. On getting to the respondents, we ensured that the consent was taken. Then we told them that we are not going to disclose their identity. We told them the benefit that surrounds partaking in that particular research work. And those people that didn't really show an interest, we exempted them. And at the end, we met some people that are not even literate enough. They could not even read. But with the help of the research assistants, we were able to interpret. We were able to pick the necessary option that they wanted to pick. And we checked for the completeness and the accuracy of the instruments used. Then we now send it down to the data analyst. The data analyst was able to help us to make the interpretation for the frequency, and then we talked about the hypothesis, test of hypothesis. We make use of a chi-square to interpret the hypothesis. In the aspect of ethical consideration, before leaving the school, we were able to meet with the UNIMED ethical committee. They approved the instrument and the work. And also, on getting to the Ministry of Health, we were able to get the ethical approved. And at the same time, we ensured that we took consent and assent of the respondent before giving it to individual. And as I rightly said, we told them that their identity will not be disclosed before, during, and after, and we ensured that. So, the results and discussion now. I said in the instrument we have 4 sections, but for this presentation, I'm going to talk about the 3 sections, which number 1, talking about the social demographic. If you look at it very well, more of the respondents, their age is above 55 years. And there are more of male, though we still have female among them. But when you look at the figure of the respondents there, we have like 59.6% happen to be men. Then the level of their education, majority of them, they don't even have education, though some stop at the secondary level. The year of experience, majority of them is above 13 years of experience. And I picked this particular one to be my discussion. The findings about the years of experience, the finding is consistent with Jamelin 2020, which shows that majority of participants had 13 years of experience at their working place. And therefore, it's expected if somebody has spent much more time doing certain things, we are expecting individuals to be able to celebrate this issue of using preventive measure. But it's the other way around at the end of the work done. So the second one, talking about the awareness, the result shows that majority of the respondents, 59.2 of them, they were not even aware of those risks that surrounds their occupation. And with this, this result agree with Sarah et al. 2015, who reported that awareness of occupational hazards among cement sellers in Nepal were poor. And lack of awareness of occupational hazard can actually make the cement sellers to be at risk of these occupational hazards. Now, talking about the preventive measure practices among them, the result also showed that 53.3 of them, more than half, they didn't even practice this issue of putting on the face mask or putting on the hand gloves. Therefore, these findings also disagree with Chanchai 2021, who reported that there was positive practices among respondents in Iran. Then, concerning the relationship between the awareness level and the preventive practices, with the use of chi-scale, the report shows that the p-value is 0.001, which shows that there is a significant relationship between the two variables. And this one is in agreement, the finding corroborates with Emmanuel 2021, who found a strong relationship between the awareness and the prevention level of occupational hazard among cement sellers in Niger, Delta, Nigeria. Now, in conclusion, there is basic level of awareness about potential hazard, but poor preventive practices among the cement sellers, because they could not really comprehend why they needed to put on this particular face masks or the recommendation for this. When you talk about the cement sellers, we have them around us. When you are able to achieve healthy community, nurses too will enjoy from it. And as you are even sitting down here, some of them have participated in ensuring that this structure erects well. Now, the recommendation. Cement sellers should be advised on proper use of personal protective equipment just to prevent inhalation of cement dust, which can cause respiratory diseases. Another recommendation, there should be health education given to them. Health education on proper handling and lifting techniques program can be organized for them so that they'll be able to have more value on the usage of this protective equipment. There should be health surveillance, because during the course of research, we got to know that some of them, they suffer from catarrh, headache. In fact, somebody had fracture. They don't even know the lifting techniques when they are carrying this particular cement. Therefore, there should be health surveillance and medical screening for early detection of health problems. Here I have my selected references. Thanks for listening.
Thank you, Dr. Elemi, for that beautiful presentation. Please, all questions, let's just note them down. After the presentation, we can be asking, or we make it first thing before we start tomorrow's discussion. Thank you very much. So please note down your questions. So we have the third presenter this afternoon is in person of Akinbola. Akinbola, sorry. Clap your hand now. Okay, you have the floor.
Thank you very much, ma'am. Standing on the existing protocol, my name is Akimbola Shomoshalewa, and I'm going to be presenting my project topic titled Effects of Breast Cancer Education on Knowledge of Breast Cancer and Practice of Self-Breast Examination among Female Undergraduates in UNIMED, Ondo. Breast cancer is the most commonly diagnosed malignant tumor, as well as the first cause of cancer death in women worldwide. Breast cancer occurs in every country of the world, in women at any age after puberty, but with increasing rates in later life. This is to say that as we grow, as we age, we are more predisposed to breast cancer. And self-breast examination is a simple, cost-effective strategy for the early detection of breast anomaly, especially in resource-poor countries such as Nigeria. Breast cancer is a public health concern that affects women across the globe, especially in developing countries, in whereby Nigeria happens to be one of them. And in 2020, to know the burden of breast cancer, there were 2.3 million women diagnosed with breast cancer and 685,000 deaths globally. That's almost a million. And for you to know that breast cancer is indeed a public health concern. Despite the awareness and knowledge campaign, there is a lot of awareness and knowledge campaign about the subject matter. But even at that, there is still late presentation, leading to poor prognosis and outcome. And a study by Zaka et al. Revealed that there is still low level of knowledge of breast cancer, SBE, and also the practice of SBE. And a study conducted in Ondo State by Mojisola recommended that awareness campaigns should be carried out to reduce the incidence and mortality of breast cancer in the state. With all this literature review, I think there should be a need for this study. Hence, the need for the study on effect of breast cancer education, knowledge of breast cancer, and practice of SBE among female undergraduates in UNIMED Ondo. Study design. A one-group pre-test and post-test quasi-experimental research design was used for this study. It was a one-group, and there was a pre-test, there was a post-test. Educational information on breast cancer and SBE was administered, and SBE procedure was demonstrated, and audiovisual aid was also used. The educational information bordered around the risk factor of breast cancer, the signs and symptoms of breast cancer, and also the step-by-step, a flow chart on how to demonstrate this the SBE procedure. And pre-intervention data was collected, after which educational package was administered, and post-intervention data was collected twice, immediately after the intervention and 6 weeks after the intervention. A multi-stage sampling technique was used to select 95 undergraduate nursing students in UNIMED, and total enumeration was used for this study. University of Medical Science was randomly selected among the 3 tertiary institutions we have in Ondo town, after which nursing science was purposely selected because they have the highest population of female undergraduate students. And also, 200 level students was purposely selected so as to prevent knowledge bias, because it is assumed that 300 level and above would have been taught how to do breast cancer as part of the educational curriculum. And a self-designed questionnaire was used to elicit information from the students, and the instrument was tested for reliability among students from MLS department, and a Cronbach alpha score of 0.8 was achieved. Data was collected in 3 phases, like I mentioned earlier, using a self-designed questionnaire. Pre-intervention data was collected, breast cancer education administered, and post-intervention data immediately after the intervention and 6 weeks after the intervention. Data was analyzed using SPSS version 27, and t-test and chi-square was used for information statistics at p less than 0.05. T-test was used to compare the mean of the students both before the intervention and after the intervention, and ethical approval was also obtained from the Ethical Research Committee of the university. This is a bar chart showing the results presentation. This is knowledge of breast cancer, knowledge of SBE, and the practice of SBE. For knowledge of breast cancer, at pre-intervention, the percentage was 48.4, which increased to 98.8 immediately after the intervention. However, there was a slight decline to 93.3, which shows that probably the students could not retain the knowledge. And for knowledge of SBE also, the pre-intervention percentage was 50.5, which increased to 98.80 after the intervention, and 6 weeks after, it dropped also to 85.60. However, for the practice of SBE, The pre-intervention practice score was 44.20, and it increased to 58.8 immediately after the intervention, and it greatly increased 6 weeks after the intervention, that is post-intervention, to 85.60. And this is the t-test result to compare the mean. It is obvious that it was significant. Pre-intervention, knowledge of breast cancer, knowledge of SBE, and the practice of self-breast examination. And also, these are the result hypotheses. The first one, there is no significant relationship between the level of knowledge and the student practice of SBE. And this was kept like that because it was not significant. And also, chi-square was used to test the relationship between the students' knowledge of breast cancer, student practice of SBE, and some socio-demographic variable. And it was discovered that ethnicity and marital status was significant. Implication of study. Based on the finding from this study, it can be deduced that female undergraduate students had average knowledge of breast cancer and SBE before the intervention. However, they had average knowledge for both breast cancer and SBE. However, for the practice of SBE, it was poor before breast cancer education. But breast cancer education led to a significant increase in knowledge of breast cancer by a mean gain of 12.01, a mean gain of 6.68 for knowledge of SBE, and a practice gain of 2.32 for practice of self-breast examination. This is a wide increase, if we are to say. The result of this study provided evidence for best practice in nursing, encouraging the incorporation of breast cancer education in clinical setting and community outreach. So we can see that from these results, this is a good literature to back up our, if we want to incorporate anything into the curriculum and community outreach. And also, there should be collaboration between nurses, educators, and healthcare institutions to develop comprehensive breast cancer awareness program, integrating nursing practice. If we can do this, with what we saw, there was definitely a knowledge gain, both for the knowledge and also practice, which means that they definitely practice. And as it was said earlier, SBE is an early detection practice that can be used to detect breast anomaly. I believe that if this can be incorporated and healthcare institution can develop comprehensive breast cancer education, breast cancer awareness program, it can greatly reduce the mortality and the morbidity of the cancer, both in Nigeria, both in Ondo State, Nigeria, and the whole world. And this are the selected reference. Thank you very much.
Thank you. So there was knowledge gain, there was increased practice after intervention. So simply put, when we are practicing by the bedside, let's not say people are aware. You can imagine, nursing students for that matter, just about 50% had good knowledge. They were until after the intervention before their knowledge increased and their practice also increased. So let's try to increase the awareness campaign so that we'll stop having late presentation of breast cancer. So our next presenter here, please excuse me. So the next presenter, Ojefia Praise, is presenting.
Good afternoon, everyone. Good afternoon, distinguished guests, my respected dean, and my esteemed colleagues. My name is Ojefia Praise, and I'll be talking about the perceived impact of burnout and their coping strategies in the University of Medical Science Teaching Hospital. I believe most of us here have gone for posting before. Yeah, and we tend to find out that when we go for posting, during the posting, we find out that most of the nurses are actually stressed out. Like, there are some kind of emergencies that will occur, and you'll be like, the nurse is going there, the nurse is going there. There might just be only one nurse in that particular unit at that particular point. And sometimes I tend to ponder that what if there are no student nurse to assist this nurse when we're on section and all? So that made me go into this topic particularly. So we'll be looking at the perceived impact of burnout. Firstly, health workers. Health workers are the brain boss of the healthcare system in any country, region, or place. The health workers, they include the nurses, they include the doctors, they include the physiotherapists and all. But basically, we'll be looking more into nursing. They are saddled with the responsibility of providing essential services to the end that the population can have a sustained well-being. Yeah. So these healthcare workers, they provide services for everybody, as we all know. You get. So we'll be looking at stress. According to the American Psychological Association, it defines stress as a feeling of being overwhelmed, worried, or run down. So is this stress that the nurses pass through that leads to what? That leads to burnout. So burnout is often found among those working in very demanding professions, such as nursing. We all know that nursing is a very demanding profession. You have to always be on your toes. You have to always there. You have to be attentive. You have to pay attention to what is going on around your surroundings. So now let's look at the statement of problem. Stress among health workers arises from multiple sources, including excessive workload, emotional demand, and the organization factors. Now let's start with the organization factors. We all know that most people, the reason why they are leaving the country is because they feel that the money they are earning here is not enough to take care of their needs. Yeah, if you look at some of all these nurses, it's not only nursing they are doing. Most of them try to go into another business in order to be able to provide for the family. And do you expect such nurse to come to the hospital and give their 100%? Is it possible? It's not possible. That's why the Nigeria healthcare system needs to do better. They need to do better, and doing better is not just starting from just the state. It starts from the federal level. They need to provide more funding for these nurses, and also that they'll be able to give the 100% best. Like I said, the Nigeria healthcare system is bedeviled with chronic underfunding, dilapidated health facilities, poor staffing, inadequate working tools, which has been source of stress. Looking at the inadequate working tools, there are sometimes that you're in the posting. Let's say you're in the antenatal clinic or something. They might need a particular instrument and you will not find it there. You have to go to another unit to go and look for it. Have anybody experienced that? It happens a lot. Now, the consequences of burnout, you all know that if the nurses are not capable of giving their 100%, it's going to what? It's going to tell on the patient. Do you guys agree? Because they will not be able to what? They will not be able to what? Take care of the patient as much as possible as they can. Given these challenges, this study aims to understand the multifaceted nature of stress faced by healthcare workers and develop comprehensive strategies to manage it. So now we'll be looking at the coping strategies. But before then, our objective, we want to assess the perceived impact of burnout, want to assess perceived burnout among nurses, and want to look at these coping strategies that they can use. Okay, for our study location, we use the University of Medical Teaching Hospital, Ondo State. Our population, we use nurses working at the UniMed THC. And our sample size, we use 148 nurses. Yeah, our study design. This study employed a non-experimental descriptive research designed to obtain information using a structured questionnaire on perceived impact of burnout among nurses and their coping strategies. So we shared questionnaires to the nurses in the UniMed THCA. For our sampling size and sampling techniques, stratified sampling techniques was used in this selection of nurses as the study setting. The nurses were divided into strata. They were divided into departments. I will show you the graph about that. And after we use a total of 200 nurses we are taking. So using this, we can see that for surgery department, there were 60 nurses. For pediatrics department, there were 40. For medical ward, there were 70. For the ICU department, there were 30. Giving you a total of 200 nurses. But remember I said the sample size we used was 148 nurses. We got that sample size from 148 nurses using the Taroyamin formula, to get that 148 nurses. So using this tractum equation, tractum size over population times sample size, you get all this. So because of time, we need to move further. Okay, the instrument. A 4-section questionnaire was used for data collection. The instrument was a structured self-designed questionnaire with reliability score of 0.76. For the method of data collection, I already said we use our questionnaire, and each of the nurses took about 4 minutes to fill the questionnaire. For our statistical analysis, the data was analyzed using the statistical package for social sciences. Chi-square was used for inferential statistics with our p-value less than 0.05. For ethical consideration, we took the ethical approval was obtained from the Health Research and Ethical Committee of the University of Medical Teaching Science. So this is our graph. This is our presentation, our social demographic table. And for this social demographic table, it tells us that the percentage of people that has good knowledge about burnout, and it is 82.4%. But do you know that it's not about having good knowledge about burnout? Because most of all these nurses, they all know the meaning of burnout. They know when they are stressed. But does that prevent it? The answer is no. The nurses cannot prevent it by themselves. The nurses need the organization to be able to prevent it. It starts from the top before it goes down. So for the discussion of results showed that majority of respondents had good knowledge on burnout with a percentage of 82.4%, which corresponds with the study according to Francis et al. So, like I already said, it's not about having the knowledge. You might have the knowledge and still be undergoing stress, and the nurses most time, they can't do anything about it. The reason why they cannot do anything about it is because you don't expect the nurses to be providing some basic facilities in the hospital. Is it possible? From the little money they are getting, is it possible? It's not possible. That's why with most of all these nurses, especially the young ones coming up, they have this jackpot syndrome. They feel that if I don't do nursing, there's other thing I can do. You get? So I know this notion that they were saying that nurses are wicked. So some extent, it's not all that are wicked, but the ones that are wicked, I kind of understand where they are coming from. Because if I'm the nurse and I'm being underpaid and I'm passing through stress, do you expect me to give top quality care? Is it possible? So for our implication of findings, continuous education, training, and fostering a positive attitude are essential in ensuring that nurses effectively utilize good coping or adaptation measures. Like I already said, it's not about giving nurses education. It's not just having the education that, okay, this is stress, this is what I should do, I should just relax, I should just rest. We need more staff, and before you can get that staff, the government needs to do something. They need to ensure that nurses' salary are increased. We all know that nurses in this country are undervalued. Am I right? So when the nurses' salaries are increased, you find out that a lot of people will still want to work. They'll still want to put in their best. And I know some people, they want to put in their best with their passion and all. But let's be honest, will that passion feed you? Will the passion feed you? Nurses, answer me now. So in conclusion, the study revealed that nurses had good knowledge of burnout. Despite the good knowledge, like I said earlier, there's high level of burnout among them, leading to effects like abstinence from work, inability to carry out their professional duties, physical challenge, mental and emotional challenge. So if sometimes you notice in the world that the nurses might be kind of observing a patient, but you try to call their attention, you find out that they are not really there. Their mind are passing through a lot. They are going through a lot personally. So when they are going through a lot personally, it becomes difficult for them to be able to take care of the world in the way they should do. Proper dissemination about the facts related to low back pain should be disseminated to nurses and other medical practitioners so as to improve workplace effectiveness. Thank you very much.
Thank you very much. You see the people are applauding. Thank you very much. So keep your questions. Tomorrow we'll be trashing them. And today has been interesting, isn't it? Oh yeah, this last 10 minutes, please be patient. You have the last presenter now. Okay.
Good afternoon, everyone. Yeah, permit me to stand on existing protocol. I'm a bit under the weather, so please excuse my voice. I'm Agumbi Adoluwadunsin, and I would be presenting on my research study on the assessment of knowledge, attitude, and practice of cervical cancer screening among women in Odoshida community, Ondo Town. So basically, this research is basically exploring what women know, that is the knowledge, how they feel, and what they actually do when it comes to cervical cancer screening. I will be examining if these three things align all the time. So I will take us through these key parts of the research, from the problem to our findings and the recommendations. As an introduction, cervical cancer has always been a serious issue, and it still remains a serious public. Excuse me, please, I need decorum. Yeah, it still remains a serious public health concern, particularly in places where there is limited access to screening and vaccine. In 2020 alone, there were over 600,000 new deaths that were new diagnoses of cervical cancer, and 340,000 of them actually died as a result. So here's the thing: cervical cancer is preventable, and early detection of cervical cancer helps to save lives. So why are these women still not getting screened? That was one of the questions that led to this research, and this is why this study is going to be assessing the knowledge, attitude, and practice of cervical cancer screening. So moving on to the statement of problem. Despite awareness campaigns of cervical cancer, we've come to realize that the uptake of this cervical cancer screening is actually low. And preliminary observations in Ondo Town have shown that women have several levels of awareness. Some of them have misconceptions about cervical cancer, and that has influenced their decision to uptake cervical cancer screening or not. So the questions that we asked in the course of this research is, what did they actually know about cervical cancer? How do they feel about going for the screening? And are they uptaking these cervical cancer screening practices? Understanding this would help us to better understand the targeted interventions we need to give to these women, and also the ones that will work for them. Our broad goal in the course of this study was to assess the KAP, which is knowledge, attitude, and practice of cervical cancer screening among these women. And specifically, we checked how aware they were, what their attitude towards the screening was, and if they took the screening. Moving on to my research hypothesis, we tested these three null hypotheses. If there was a form of significant association between their knowledge and their practice of cervical cancer and the screening, if the knowledge and attitude, if they are connected, and if these three variables, the knowledge, attitude, and practice, if they have an influence on each other. Moving on to theoretical framework, we use the health belief model as a foundation of our study, and this health belief model basically helps to explain why people make the health decisions that they make. The health belief model is based on 5 key beliefs: the perceived susceptibility. Now we ask, does this person think that they are at risk of cervical cancer? Do they think it can happen to them? The perceived severity. Do they think this health decision, do you think it's very serious? Do you think it can have an effect on you? Then the perceived barriers. Are there certain obstacles that prevent you from making that certain health decision? And what are the external stimuli that prompts you to go for the health decision? Now, applying these 5 beliefs that I have just outlined, when it comes to cervical cancer, we're able to see that, did these women believe that they can have cervical cancer? And there was something we noticed in the course of this study. They said, God forbid, it can never happen to them. So they believe that they are not at risk of cervical cancer. Hence, it shows that they do not have positive, they do not believe that they are susceptible to cervical cancer. Then the other 5 beliefs that I have outlined earlier. So from this application, we can ask, is it that these women are likely to go for this screening if they believe that it is effective, or are they simply scared or discouraged? Do they feel like they'll be embarrassed if they should go to a healthcare professional to go for this screening? So these beliefs helped us to understand what shaped the actions of these women. Moving on to my methodology, we used the descriptive survey and focused on women of childbearing age in Odoshida community. Using systemic sampling technique, we selected women from every third house that met our criteria, and we used the Cochrane's formula to calculate our our sample size, which gave us 385 participants. We pre-tested our questionnaires in larger community, and it gave us a very good reliability score of 0.8. Then we gathered data over 2 weeks using interviewer-administered questionnaires, and the data was analyzed. Using the SPSS with a significance level set at 0.05. Ethical approval was obtained, and these participants gave informed consent. Looking at our results, from the charts you can see that the level of awareness of these respondents, for those who are aware, there was quite a high level of awareness at 75.3%, and a little low for those who were not aware. And for the level of knowledge, we can see that it is very, they have very fair knowledge of cervical cancer. From that orange part of the chart, you can see that 95% of them had quite fair knowledge of cervical cancer and its screening. Meanwhile, only 4% had poor knowledge, and only 1% of these respondents had very good knowledge. So most of them just knew a thing or two about cervical cancer and cervical cancer screening. From here, you can see the attitude and the practices of these women with cervical cancer and cervical cancer screening. And you can see from this chart that the attitude of these women is very high. They have very positive attitude to cervical cancer and its screening at 88.3%. And while they had those that had negative attitude towards the screening was at 11. Then their practice, we can see that there is quite a high percentage of the positive attitude, but for the practice is at 25%. But we can still see that significant influence in between them, although the uptake of cervical cancer still remains low. So by testing this hypothesis, we were able to see that knowledge did not influence both the attitude of these women towards cervical cancer screening and the practice. But we were able to see that attitude significantly affected the practice of cervical cancer screening. So that is to say that even if a woman knows about a screening, it is her attitude that actually determines if she's going to go for that screening or not. The implications of these findings was that despite their good level of knowledge, there was a disparity in the level of practice. So this shows that when we want to go for researches like this, we do not need to focus only on the awareness of these women, but their attitude. We need to find a way to change their attitude through targeted interventions. How do we do this? By desensitizing these women, helping them realize that there are no disadvantages for going for cervical cancer screening, and involving the community in changing their minds and attitude about cervical cancer. In conclusion, we can see that the women of Odoshida community, they are aware of cervical cancer and its screening, and they have positive attitude towards it. But unfortunately, the uptake of cervical cancer screening is still very low. We recommend through the use of this study that more intervention programs are done in order to bridge the gap between knowing and doing, not just knowing and knowing. Thank you very much for your attention.
Thank you. Another round of applause for all of our presenters. I think they did beautifully well. So when we are asking you to do your project, do it well, yo. It is good project that we are going to present. If you don't do good projects, you cannot come and present. So sit down and stop doing ChatGPT. And if ChatGPT help you, sit down and read it and write well. Okay, we have had a wonderful day. Thank you, everybody. Our pioneer dean, the dean, everyone, our lecturers, all our PG students and our students, we say a very big thank you. Don't go out yet. We are going to be closing with the nurses' anthem today. So let's be on our feet. Let's be on our feet as we take the nurses' anthem. Let's be on our feet. We are meeting for 9 tomorrow. Registration starts by 9, so please don't be late. Don't do African time that you did today. Oh, you know there's no opening ceremony tomorrow. No opening ceremony, so let's come on time.
We are built on integrity and discipline that transcends through every generation. sees of caring, and every tone of humility and service. We are specially ordained for this vocation. Yes, I'm proud to be a nurse. From near and far we have gathered with one goal, to uphold the good name of our profession, and for neatness and splendor, you for understanding, and for responsiveness, and selfless service, and innovative and initiative, and for nobility, G for gentleness and love, no cease of grace, no cease of caring, and every tone of humility and service. We are specially ordained for this vocation. Yes, I'm proud to be a nurse.
Give a clap offering to yourself. Thank you, thank you. We'll be expecting you tomorrow by 9. Thank you very much.